We shall now go on to the neuro-ophthalmic contributions to the optic disc presentations. And we have with us a very eminent neuro-ophthalmic exponent of our country, Dr. RASHMIN Gandhi. And he is going to elaborate on evaluation of optic disc edema unilateral causes. On to you, Dr. RASHMIN.
Thank you so much, Dr. Chitra. It's an honor to be part of these ARC program for the postgraduates. So my job here is to talk about unilateral disc edema. How do you approach these patients? So these are the questions that you need to ask yourself. Is it just an elevated disc, or is it really a true disc edema? Is it unilateral or bilateral? Bilateral, Rohit will cover next. Then you perform all the optic nerve function tests, look at the pupil carefully, color vision testing, visual field testing. And after you have established that it's a true disc edema with optic nerve dysfunction, you ask yourself, is this disc edema coming because of an optic nerve pathology? Is it coming from above? Is it related to something happening in the white matter tract or in the brain? Or is it coming from below? Is it coming because of any eye problem? And Avinash beautifully illustrated some of the causes of disc edema, and Dr. MPS as well, disc edema, which can be related to the ocular problem. So let's look at this case. This is a 46-year-old female who comes to you with a sudden painless loss of vision. She woke up with this loss of vision in the left eye. Visual acuity on presentation was 624. She has been a case of hypertension for the last 2 years. And this is how her optic nerves look like. This is the affected eye, which has a small hemorrhage on the surface of the disc, and there is a disc edema. The other eye, you can see here there is a little pallor, though she didn't complain of any problem in the past of the right eye. So the question, of course, is what is happening to the optic function? And for the postgraduate students, this is the list of the optic function tests that you should be familiar with. RAPD is the most accurate and objective optic function test. Visual fields in the exam or in the clinic can be performed with concentration, penciler, or with a red target, brightness sensitivity, and color vision testing. Of course, examination fundus will give you the idea about the morphology of the optic disc. So once you have performed the optic nerve function test, the second question is, what has caused this unilateral disc edema in this 46-year-old female? These are the potential culprits. It can be optic neuritis, ischemic optic neuropathy, compressive, nutritional, or hereditary. This is a broad group of disorders can present to you with an optic neuropathy. As Prem discussed, hereditary optic neuropathy, only hereditary optic neuropathy which can present with an acute or subacute presentation would be LHON, but that's much more common in males. It's very rare for a female to have a full-blown clinical picture. Nutritional, metabolic, or compressive optic neuropathies generally would be bilateral, would have a gradual onset and a progressive course. So you're probably looking at an inflammation or an ischemia. Now, in a 46-year-old female with no pain, and if the patient has an altered visual field defect, hypertension which is fluctuating, and as Avinash mentioned, if there is an hypotension, then you are probably dealing with ischemic optic neuropathy and non-arthritic anterior ischemic optic neuropathy. What do you do next? Well, roll-up blood test, carotid Doppler is debatable. Neuroimaging only if there is an atypical presentation, namely patient has acute pain or the vision loss is progressive. So what can we offer to this patient with the non-arthritic AION? Sleep apnea, drugs like Viagra should be avoided in males, amiodarone should be substituted, and smoking should be stopped. The other case, 70-year-old female, acute painful loss of vision. Patient was complaining of headache, and there is a profound visual impairment. And here you see here, the right eye optic disc is fine with a normal cup, while the left eye disc has a lot of disc edema with what we call a pallid disc edema. So in an acute loss of vision, profound visual impairment in the age group of 70-75, patient complaining of headache, patient having tenderness of the scalp, you are probably dealing with arthritic anterior ischemic optic neuropathy. For the postgraduate students, if you are asked about this in the viva or in the exam, you need to mention that it's an emergency. The patient requires an admission. ESR has to be done immediately, and patient has to be started on steroids immediately. Not so much to improve the vision in the affected eye, but to make sure that vision does not go down in the other eye, because the other eye can be affected in the matter of few hours. You look at case number 3, and a lot of this was discussed by Prem and others, where 24-year-old female, sudden blurring of vision for the last, onset was 2 weeks ago, and vision started improving for the last few days is what she's saying. So probably you are dealing with optic neuritis. The question comes in, obviously, and we have been taught or at least a few years ago, we used to think that optic neuritis in most of the cases would be retrobulbar optic neuritis. But this is a paper which was published long ago, and they said that in Indian population, more than half of those patients actually had involvement of optic disc on presentation. And now as excuse me, Prem mentioned, because of this NMO and anti-MOG antibody related optic neuritis, we see a lot of these optic neuritis presenting with disc edema. So that should be one of your differentials, optic neuritis, as one of the differential in patient who has a disc edema, unilateral disc edema. What do you do now? You perform HVF. OCT was discussed briefly by the discussants. Neuroimaging, probably 2 decades ago, we would have said that if neuroimaging is not available, it's fine. But now we prescribe neuroimaging, MRI brain orbit with contrast, with fat suppression for almost everybody, because that would help us to give to have an indication about presence of NMO-related optic neuritis early. So this is the chart about the optic neuritis. So that's about optic neuritis. We are looking at approach to a patient with unilateral disc swelling, non-arthritic AIN, arthritic AIN, and papillitis or optic neuritis. This is a 46-year-old male again with a sudden loss of vision. He had a redness in the affected eye 3 days ago, where he went to a local doctor. Vision then recorded was 6/9 in the affected eye. But when he presented 3 days later, his vision had gone down to no PL. So rapid, profound visual impairment. And this is how his optic disc looked like. Look at a profound, angry-looking disc edema with a lot of hemorrhages. And if you look at it carefully, there is a rod spot here. So when you have such a massive disc edema, one of the other differential which comes in the mix is infiltrative optic neuropathy. Conditions like leukemia, some of the infections can produce infiltrative optic neuropathy, where optic disc really swells up, and they can have some of the associated features like this. This patient had thickening of the nerve with perineuritis. So these are the patients who came to you with loss of vision. Now, what if you saw a suspicious disc in somebody who had just come for a normal disc evaluation like this? This patient came for a normal eye examination, and you found a disc which looks like this. Obviously, this does look elevated, but if you look at the surface of the disc and at the blood vessels, they are clearly visible. What it tells you is that there is no axonal swelling. So this is a pseudo disc edema. This patient had a buried drusen. So this is a montage of some of the patients which can come to you with a unilateral disc edema or asymmetrical disc edema or a bilateral disc edema. This is a case of...
Sir, you have 1 minute remaining.
Sure. This is a case of neuroretinitis. This looks like a papilledema where patient would have a similar feature in the other eye. Patient having a retinal problem and a disc edema. Here there is a sectoral disc edema signifying AION. Disc edema with a optical ciliary shunt, probably a compression of the optic disc, generally seen in meningioma. Arthritic AION with BRAO. Please remember, it need not be neurological always. This patient has overfiltrating blood and a disc edema, so hypotonic also can come to you with disc edema. And this is just for completion's sake, bilateral disc edema, but a lot of hemorrhages and heart exudates in the mid periphery. This is a case of malignant hypertension. So to summarize, if the patient comes to you with a disc edema and acute loss of vision, first establish a structural problem, optic nerve versus visual pathway, establish the etiology. Please remember, if you're dealing with optic neuritis, don't forget, especially in India, about NMO and MOG. MOG also is being seen now in patients who had COVID or even had COVID vaccine. Bilateral simultaneous loss with similar looking field effects is more likely to be visual pathway problem. I thank you once again.
Thanks a lot, Dr. Rashmi. That was a very elaborate talk. Murli, anything to ask? Dr. Prem?
Dr. Prem, any comments?
No, I think this built on some of the points that were made already for the PG's sake, that it's very important to ensure that you take a good history, that you correlate what you're seeing on exam with the historical findings in order to try to narrow down what your differential diagnosis might be and to find the right cause. And I think that this was a great introduction to what you do first. It's a very complex topic, of course, as to how you branch into evaluating the different diseases and treating them, but there's a very nice initial approach to the patient.
Dr. Chitra, can I make a comment?
Yes, yes. Yes, Dr. Jyoti.
Yeah, so I think because it's for PGs, I like to reiterate that when you're talking about RAPD, it's a relative afferent pupillary defect, which means with relative to the other eye. So in a short time, if the RAPD disappears, because normally it takes about 2 to 3 months for the RAPD to resolve. So expect that the other eye is also developing. So then we are looking at an asymmetrical bilateral involvement. That's first. Secondly, in a case with hypertension, a person is on treatment, ask for whether the medicine is being taken in the night, because possibility of nocturnal hypertension is common, and these patients can have a risk of any ion, especially when you're taking history. This becomes important. And finally, if you have a patient with neuroretinitis, like a presence of macular star, then it's unlikely that patient has a demyelinating optic neuropathy. So they are unlikely to develop MS. Thank you.
Yes, thank you.
In
Anything else?
in non-arthritic ischemic optic neuropathies, I mean, is the nocturnal dose of antihypertensives important, or is a 24-hour BP recording important? I mean, what can we do to prevent the fellow eye involvement?
Yeah, absolutely. As Avinash mentioned, it is presumed that these patients have a loss of autoregulation. So that little bit of hypotension that physiologically patient get, and if he's already on antihypertensive in the night, that hypotension generally is compensated by autoregulation. But if the autoregulation is not functioning, these patients can have edema, and that's the reason why there is a crowded disc and they wake up with the loss of vision. So I think this is something which you need to discuss with the physician to make sure that you are suspecting that patient has NAION because of a nocturnal hypertension, and then you can deal with it. All NAION, you need to get the physician on board because they all have vasculopathic risk factors, and NAION is developed because of vasculopathic risk factors not being under control, and it has to be controlled very well.
I will mention one thing about the nocturnal hypotension and nocturnal antihypertension. Large meta-analysis that came out of Scandinavia that showed decrease in cardiac death and adverse events in the patients who took their blood pressure medicine at night, but not in the morning. So it's important, again, to have the patient's physician on board, because changing their medicine to the morning may actually negatively affect their health overall. So just again, not a decision we are going to make, but to make sure that the other physicians involved understand the issues too.